I think I need to. Hello.
Hello, how are you? Do you have my?
Yes, I do have your video. Do you have mine?
Yeah, sure.
So let
Yeah.
me ask Gomez to
Yeah.
come. It seems it is okay
Yeah.
now.
Try to give him a request. It's better. I
I will
think.
send him a request.
Yes, I
Gomez,
can see him as well. Yeah. Finally.
do you have my video? Hello, brother.
Don't say no.
Please don't say you don't have my.
It's possible. It's possible to stay more than two people at the same time. I don't know.
I think he doesn't.
Gomez, do you have my video?
No, I can see only Mona.
Oh, I have all of you.
Really?
Yeah.
So it is very weird.
it's
You can see Ali, Mona.
Can you go out and completely close your Instagram and then rejoin? Because I think it will fix the problem, because I did that and it was fixed. I ask you to do that completely. Please close the Instagram and then rejoin the live. I will talk to Mona and I will wait for you. I think it will fix the problem. Okay. Sorry.
It's like very weird.
I don't know what is going on
so
behind
weird.
this.
Yes, it starts playing with us right now.
Yeah, sure.
So how are you,
Very
doctor?
Thank
How's
you.
everything?
How are you?
I'm good, thank you. Good.
I saw your story and you seemed you had a child patient and you were
Yes, I
very
had a pedo
exhausted.
patient. He was 6 years old, and it was really difficult to manage him. But I did pulpotomy on 2 teeth. Thanks God.
Yeah, sure. You are so talented. You can manage everything you want.
Oh, thank you. No, it's not like that, to be honest. Hopefully, it's.
Oh, it's good. It's fine now.
That's perfect.
Okay.
That's perfect. Yeah, finally.
Finally, we did it.
Yeah.
It was a stormy start, beginning for the show. Let me start with that. I have bad news from Mustafa. Mustafa's father is not good and he is at the hospital with his father. I pray for his father and I hope he will get healthy soon. So Mustafa sent, hopefully. Mustafa sent me the PowerPoint of the tonight's show and I will share it, and then we will go to see the cases and we will discuss.
Sure. Good.
Okay, good. So let me go for the show. I will. Do you have the video?
Yeah. Yes. Perfect.
Let me start. This is the first show of the Endo Leaders Show Academy, and we are so delighted that we have the chance to be here and start with the esteemed endodontists around the world. Thanks, Mona, and thanks, Komen, for accepting our invitation. It will be a great discussion, and I think everyone will enjoy this discussion. So we are here on the behalf of Expedient Company, and the Expedient Company is the sponsor of this show, and we are happy that we have the chance to have a cooperation with the Expedient Company. I will start with the first case, and I think it is the Gomez case. I ask you to explain a brief explanation about the history of the dental and medical history of the patient, and I will go for the procedure that you have done.
Okay. First of all, I'd like to thank the invite. It's a great pleasure to be here with you. I'm here in São Paulo at mid-afternoon, almost 3:30. And this case, I treated this patient a few years ago without magnification. and it's important to say that a lot of problems I have to resolve because I don't have magnification at that time. This patient become to retreat for a retreatment. She has pain. She has pain, and we can see that the limit is very bad, bad limits. But when we can, at this moment, I have no tomograph tool, and it's very hard to work without the equipments that we have now. And then I try to reach the working length, and it's not easy because we have a very great classification in these scanners. And while trying to reach the working length, I separate an instrument. And you say it's bad, okay, but it can be worse. We know that it can be worse. Then I tried. My fight was to bypass the instrument, and while bypass the instrument, I perforate this root. I think I like to show the cases that we don't make only good things. Sometimes trying to do good things, we turn the case worse. But it's not the end. Sometimes we can fight and to make it better. And then here in Brazil, they say that we don't. It's difficult, like Spanish. Rafael Nadal, like tennis, we are hard to say no. I can't do it, and we try. And with I use manual files. I cut the file and sharp the tip and try to bypass the instrument. And it's a lot of time, a lot of tries, but we can do it. I can do it. And the perforation was just a little problem that we can resolve with the endodontic sealer is enough to solve this problem.
Very good. And let me change my camera, and I will go for the discussion. Okay. Gomez, I think I want to ask you some question, and Mona, if you have any idea or if you have any other comment, you can say to us. Gomez, what is your approach to seal the perforation area? You said you use bioceramic sealers, yeah?
Yeah. Today, at this moment, we can choose the cement that can bring better prognosis to the case. And I think when you have a perforation, a contact with the periodontal tissue, the bioceramic is the best option at this moment. We know that the Aga Plus resin sealers are the gold standard, but sometimes the bioceramic can bring a better prognosis to some cases. No, I don't know what you think about it.
It's a great concept, and it is now growing about the bioceramic sealers that they can seal any area better than the resin sealers. But on my choice, I think it would be using MTA to completely seal the perforation area and obturate the main canal with gutta percha and resin sealer. It is another choice, but it depends on the operator.
When we have big perforations, I think it's the best approach is but it's a small perforation with a file. That was difficult in this anatomy to fool with to put consistency is very difficult. Then I prefer the seal. Sometimes if it's bigger, I think your option is the best option. to fill all the canal with a put material, now bioceramic put material, put consistent, sorry.
Thank you, thank you.
Mona, what is your idea about this approach, and what would be your approach if you have the same situation and same case?
I would use the same technique. I would use bioceramic sealer because as Dr. Gomez said, it's like a perforation with a small size. So I would use MTA, like you can see the another case, in a larger perforation to condense it very well. But here, the bioceramic sealer, it works better. What I want to mention in this case, that the most important thing in outcome of perforation treatments and managing of it is the timing. So that was good. The timing was in the same session, and the treatment was done in the same session. So the sealing was, they sealed it very well. And the other thing, the location of the perforation, it was beyond the crystal bone. So that was a little bit promising. So it will give us favorable outcome that you had it in this case. I don't know if you reviewed the case and followed up the case, but I think it will have a promising outcome.
Yeah, this case I took three or four sessions because at that moment I don't have magnification. And it's very important to say another with magnification. I'm sure that it will take me, it give me much less problems because I will be able to see the file and remove the file. I love removing files with magnification, and we have a lot of techniques today to remove instruments. I to my students that the case that I love to receive at my office is separate instruments, because I'm not the bad guy. I will be the good guy that will try to save the tooth. It's a good situation in this case.
So
you said that you removed the file from the root canal. You just bypass the file.
I make the bypass, and while the station the fragment is out of the canal. Oh.
You have talked about 5 fractures. My approach in every 5 fracture, except for the coronal 5 fracture, I will go to bypass the file because I think minimally invasive, more conservative. Because when you want to remove any 5 fracture from the root canal system, you are going to weaken the tooth structure. And this is very important for the long-term prognosis of every tooth that we are going to manage. And I was surprised because you said that the perforation and 5 fracture was your own mishap. I think the other clinician, and that's the point. It's very important that
in this case, I'm the bad guy. I'm the bad guy. And after the good,
it is very important.
Okay.
Because we only share our successful cases, but we have to mention that we as endodontists also, we can have 5 fractures, we can have perforation. As the most important thing that is that we are responsible about every mishap and every iatrogenic error that we have in every case, and we know how to handle every bad situation and every bad mishaps that we are going to face. And this is very good that no errors or any iatrogenic errors are going to threaten us. We
And has problem right now.
sorry.
yes.
Sorry,
Oh no, okay.
Oh,
It's fine. It's fine, right? Yeah. Okay.
Finally, we will discuss and we can get to a conclusion about managing perforation. Okay, let's go for the next case. The next case is a strip perforation. I think it is Mona's case, and I will be very happy if you give us any explanation if you want.
Yes, this piece of art, when I'm seeing this X-ray, it gives me heart palpitation, to be honest. So let me explain about the case. This patient was referred to me by general dentist. The treatment was initiated by the dentist, and they tried to search for mesial canals. So they drilled the pulp chamber by high-speed burrs, and they removed massive amount of dentine. And finally, I think they found the canals, and they tried to instrument the canal until they found and they saw the bleeding, and patient had lots of pain. So they dressed the canals with calcium hydroxide, and they referred the patient to me. I visited the patient, I think, few days after the first initial, treatment. So the tooth was really symptomatic, tender to percussion and palpation, and the probing depth around the tooth was within normal limit. And when I took a preoperative radiograph, I noticed two broken instruments beyond the apex, even mesial apex, and you can see here. So they tried to over instruments by rotary files, I guess, and they did strip perforations as well. So, and it was a large perforation. So I discussed about the treatment option with the patient in details, and I told the patient that because of this amount of perforation, the outcome won't be promising, so it's questionable. We can go orthograde root canal treatment and see the perforation and follow up the sign and symptom of the patient, or we might go surgical intervention or extraction and implant. So the patient didn't want to go under surgical intervention at all because she couldn't pay the cost of the treatment, and the outcome of the treatment is not promising, so it's questionable. She preferred to go for root canal treatment, continue and seal the perforation. And if it didn't work in the follow-up and it didn't heal, she preferred to extract the tooth and go for implant. So I did this case under microscope. Without microscope, I couldn't manage it. So I tried to reach the canals. I did mostly chemical cleaning of the. I didn't do mechanical because already they did over instrumentation, and I sealed the perforation area by MTA. It was large perforation, and I tried to seal it with MTA. As Ali's approach, I tried to seal the other canals with Gutta and AH plus sealer, and then I tried to seal this perforation by MTA, condensed very well. And I think I reviewed the patient after a few days, a few weeks. The tooth was asymptomatic, and then I reviewed the patient after 6 months, and the tooth was asymptomatic, no tenderness to percussion. The pocket depth was the same, within normal limits. Still, I'm going to review the patient in a year, and to see what's going on. If something happens and I found any defect or anything, this is immediate after the treatment. And by the way, the coronal restoration was the general dentist did it, and this was after 6 months. The patient is happy to keep it like this until to see the result in a year.
Very good, nice, and a very challenging case.
It was very
You managed the
challenging.
case
It was,
very perfectly. It
yeah.
needs so many skills and so many experiences to handle such cases, but you were successful. I have a question about how did you remove the gutta percha from the root canal system? Because I think there were some gutta percha
That
in the
was
perforation area.
no. That was non-setting calcium hydroxide. The tooth was not retreated. It was treatment.
So the
So
opaque area it was calcium hydroxide. It was not
it
gutta
was
percha.
calcium. They didn't continue the treatment. So during the treatment, when they saw the pain
Oh,
and bleeding, they stopped. They packed non-setting and they sent the patient to me. Yeah.
It was very opaque. So imagine that it was gutta percha. Did you go? Would you go for remove the gutta percha from the strip perforation area or not? Because if we want to try to remove the gutta percha at the strip perforation area, we may push some gutta percha at the perforation site. What would
To
you
be
approach?
I would remove it. I will try, but I will not use chloroform. I will try to use the edge file slowly, little by little, because the chloroform will melt it and it might extrude to the perforation area. That's would be my approach.
What about you,
And
I think
if
Gomez?
I will try. I think I will try to remove it with microscope and ultrasonics. I don't see another way. No?
yes, little by little under microscope we can do that. Yeah.
What about
Well,
rotary, for example, Gates Glidden? Would you use
No,
Gates
gates.
Glidden or?
again, I will not use gates.
Okay. No, I will not.
Okay. If the gutta percha goes to the periodont, I think that maybe it's not a good problem. It can stay. It can stay there. It's not the problem. The problem is the contamination in the area. Gutta percha without the tooth, we think it's not a good problem that can make bad prognosis. We prefer not, but sometimes it happens when
It happens.
we do a retreatment.
Do you agree to seal the strip perforation with the bioceramic sealers or MTA? Because some endodontists and clinicians emphasize that we cannot seal the strip perforation with bioceramic sealers because bioceramic sealers are not that as good as MTA-like materials. Do you agree with this concept?
Actually, I read a paper about that strip perforation creates lots of stress along the roots. So we have to use a material that has a good mean fracture resistance to avoid from further fracture. So among those materials, they found MTA and bioceramic putty is the best to use in strip perforations. So, and I think for me, condensing of MTA, it's much easier in that area.
Yeah, it's easier to control the MTA to put it exactly at the point you want. And the magnification is the most important
Yes.
thing
I
that we should have.
wouldn't be able to do this without microscope, to be honest. Yeah.
I want to share the case again. And imagine if you see any failure with this treatment. Are you going to do a root amputation for this case or not? You adjust it, you tell the patient to go for implant.
I won't go for root amputation. No, I would because in these cases we have to listen to patient's desire as well. My patient, she wanted to go for extraction and implant to be more promising than other options. Maybe one patient, they prefer to keep the tooth and they go under other surgical intervention. As another thing, I want you to know that this was mesiolingual canal. Even for surgical surgical approach, it was really difficult to approach from lingual side. And even if you want to go from the buccal side, you have to remove massive amount of the bone, so it will weaken the tooth. So that was the option for me to do root canal treatment, follow up. If it didn't work, extraction and implants.
Thank you.
Gomez, do you agree with Mona, or you have another idea? Yeah.
I think sometimes some say, "Oh, let's make a surgery," but the people don't. It's not able to do that. No? We have, like Mana said, we have a lot of bones bone to remove to reach the perforation. It's not easy like some think that it's possible. It's very difficult to do this kind of surgery. I think I agree with Mona. If we have no success, we will prefer to remove the tooth and make an implant.
Yeah, sure.
Yes, that's the best option, I think.
I asked that
Sure.
question because I have the same experiences. I had the patient at my residency program, and patient was referred to me for the street perforation, and it was first managed by another resident orthograde in an orthograde manner, but it was unsuccessful, and patient was eager to keep the tooth. It's very important. Mona talked about the patient preferences, and we have to hear the patient's and we have to respect the patient's choices. And the patient at that time was very eager to keep her tooth. So I ordered an CBCT, and I see that there was a buccal perforation. So I tried to do apical surgery. And when I go for the surgery, I see that there was no hope to actually save the mesial root. So I had done a root amputation for the patient, and I followed it up for I think it was after 9 months, and the patient was completely asymptomatic. But nowadays, many endodontists and many specifically periodontists do not agree about the treatments like root amputation, hemisections. But if the patient wants to save his or her tooth, we can still think about these options. I think these options, they are very good to keep the tooth as much as possible, because some patients prefer to have their own tooth, for example, about 5 years, 4 years, and it depends on the patient's preferences, and we have to hear the patient's eagers. And that was a very good point that Mona has mentioned for the patient's history.
Yes.
Yeah. Okay.
Yeah. We just have to take some care. Sometimes we decide to maintain a tooth, and we have lost bone. Today, lost bone is not good. Is a not good option. When we don't have the implants, we make treatments that we know that it will fail in a few years. But today we cannot make this choice when we have the bone losing bone is not good for the patient. We must think about it.
Because losing bone also will compromise the future implant as well. This is also we have to make in consideration.
Yeah.
Exactly.
Okay, thanks for your comments. I will go for the third case, and it is Mona's case again. This is for kitchen perforation. Please go on.
So this is an interesting case, by the way. This patient referred to me by general dentist for retreatment of lower 6. This one is lower 7. So the dentist thought there might be a ledge in lower 6, and she couldn't manage it. So she sent me directly the patient. Patient told me he has done the root canal treatment back in his own country 1 year ago, and both teeth had splintered crowns. So both teeth were really tender to percussion and palpation, and probing depth was within normal limit. When I took X-ray, I noticed lower 7, which had perforation in forcation area and periapical radiolucency on both distal and mesial roots. I told the patient both teeth needs retreatment, but the pain mostly originates from this one. So he decided to retreat lower 7 first. So I removed the crowns. The problem with this kind of teeth, the challenges that I was facing is that when we have a perforation and we didn't seal it, we shouldn't go for definitive crowns. Restoration like dental crowns. So in this case, when I removed crowns, I was really struggling with isolation. I couldn't place the clamp, and I could place the clamp on 8 and do a split dam technique, but it was really hard. At the end, with small clamp and wingless, I was able to do the isolation. And the feeling of the tooth was a thin layer of composite. When I removed it, the whole pulp chamber, as you can see there, it was filled with gutta perca. So I knew that it was lots of bacterial leakage, bacterial infection that was communicating with the perforation and of the forcation and supporting tissues for 1 year. Again, one of the important things in managing perforations is the timing, the time elapsed between the perforation and sealing it. So here it was continuous contamination of bacterial infection. So I decided to remove the GP from pulpal floor, and I saw the perforation. Then I tried to cover it with PTFE tape, and I went to remove the GP from gutta perca from the distal canals. As soon as I entered the distal canals, there were lots of discharge of exudate and pus from distal canal. So I knew that this tooth was the origin of the problem. So I shaped, cleaned, irrigated 3 canals, and I addressed that with non-setting calcium hydroxide in the first session, and I moved to seal the perforation area. In this case, also, I sealed that with MTA. And then I just placed a wet cotton pellet, and until the next session, when tooth was asymptomatic, I obturated with gutta perca and H plus sealer. And I'm going to review the case in 6 months.
Very good.
Very good, nice case, and thanks for your presentation and your explanation.
Thank you.
Let me ask you some question about this case, and please tell me your concept. The first question is that we have contamination at the forcation area when the patient referred to us, for example, after 1 month, 2 months, and how are you going to disinfect the area? Are you going to insert your needle of hypochlorite sodium in the perforation area, or how do you disinfect the area? With chlorhexidine? Do you disinfect the area with hypochlorite? Please explain in details.
Yes, I disinfect the pulp chamber with sodium hypochlorite, and disinfect that area with diluted sodium hypochlorite with the cotton little bit. I'm going to disinfect that area. Yeah.
What about you,
Gomez? How do you disinfect the perforation area?
I do normally it with sodium hypochlorite, and I think it's a good option in these situations. The photogenomic therapy, we use the. It's very good to this kind of situation. We can use the methylene blue and then irradiate with the red laser, and it's a good option. But I always working with sodium hypochlorite too.
Yes.
would you place
The calcium hydroxide at the perforation area, you will go to repair the perforation in one visit? What will be your choice?
Always in this case is very important to medication, because MTA didn't like the acid. It makes the properties bad. It not works good in the acid ambient, and it needs to use the calcium hydroxide to prepare that this space, this area, to receive the MTA with a good prognosis.
yeah,
The acidic area will not let the MTA to be set completely. We have to increase the pH of the area, and then we will go for the repair of the perforation.
That's the idea. I think when you have a perforation, in a case of without contamination, we can seal it in the same session. But with contamination, I think it's very important to medicate with the calcium hydroxide to have success when you put the MTA.
Exactly.
Yes.
Exactly, thanks. My other question is the steps of the procedure. Will you first repair the perforation and then you will go to obturate the canals, or you will obturate the canals and then you will go to seal the perforation area? Which one do you do first?
Usually, if I'll do it in one visit, like the last previous case, I would obturate the canals, then I will see the perforation. But in this case, I couldn't obturate the canal in the first visit because of the exudate and pus. So I cleaned the canal, I drained from the canals. So then I just sealed the perforation area in the forcation. The next visit, I try to obturate the canals. So it depends on the case
It
for
depends on
me.
the. And what about
Yes.
you, Gomez?
Oh, I agree. I will make it like Mona. I prefer to make this case with contamination in two sessions. I don't like these cases to do all in one session, especially when we have exudation. It's not possible. But I prefer to make a medication with the calcium hydroxide. And I prefer to seal the canal first, and then the perforation. But it depends the position of the perforation. Sometimes it's easy to seal the perforation without to compromise the canal. Sometimes we must do that at the same time. But a good option, I think, is when we have a canal so near the perforation, to seal all the canal and perforation with the MTA. It's a good option, I think.
Yes.
Not use gutta percha sometimes.
Yes, you are right. Yeah.
Yeah, in such cases, I will use, for example, a tapered 4% taper or 6% tapered gutta percha in every canals, and I will go to seal the perforation area, because when we go to first obturate the canals, we may push the sealers or gutta percha at the perforation area, and that will we have a bad effect on the final outcome of the perforation area. I prefer to completely seal the area, and then my choice is to place glass ionomer over the MTA, because I don't want my MTA to have any contact with the hypochlorite, because some evidences and some articles mention that if the hypochlorite get in contact with the newly mixed MTA, it may have some bad effects on the final setting. But it depends on the operator, and I want to hear your idea about this. Will you use the glass ionomer over the newly mixed MTA or not?
You said something very important. When we use MTA, all the times we must protect with the glass ionomer. It's a very good action. It's very important to a final setting occurs in the good condition. Very good, very good.
Did you do that, Mona, in your case?
Yes, yes, of course. Yes, it was with the layer of the glass ionomer here, because otherwise the next session it could be washed out. So that's why I just protected. Yeah, yeah.
Yeah.
And another important thing that the most important thing about managing perforation is that
I like
you
your
don't.
cup, Mona. Nice cup.
Thank you.
Yeah, yeah.
Thank you.
Okay, I want to mention that
Sorry.
no problem. Thank you. Thanks for joking. I think that the most important thing about and the most important prognostic factor for any perforation is that we shouldn't have any communication between the oral cavity and the perforation area. If we have, for example, any probing defect in such cases, I think the long-term prognosis will decrease very, very much. I had the same cases, and when I see, for example, a probing defect at the forcation area, I think it is not reasonable to go and repair the perforation, because this contamination and this communication between saliva and the perforation area will disinfect the area in the whole actually procedure, and after if you want to do any follow-up or any review of the case. What is your idea about this situation? We have a probing defect and we have the perforation. Can we still go for managing the perforation, or we can say that the tooth is hopeless?
So,
I think I
Okay, go
okay.
for it.
yes. Okay.
Go on.
Okay. What I think, the perforation alone, the communication between root canal system and supporting tissues is not the problem. This will not alone cause a failure. The bacterial infection, the inflammation will cause the migration of the epithelial or gingival sulcus that will cause periodontal defect. This will cause the failure of the treatment. So in these cases, I will try to see if we can manage it surgically. I mean, in these cases, or it might be hopeless.
Okay, if you go for managing such cases surgically, you mean you use GBR and GTR procedure, and you will use membrane or anything, or you just remove
The
the...
thing is that, okay, let me go to back to your question. Did you mean you sealed the perforation and then you had a pocket defect? You mean this?
Exactly.
So in these cases, again, it depends on preference of the patient. Some patients, they don't want to go under the surgery. And also it depends on the strategic importance of the tooth, to be honest. Sometimes implant could be better option than surgery. This is my answer, to be honest, because removing of the bone and surgical intervention when one time it fails, it could not be easy, or maybe compromise the situation more.
Yeah, especially
That we are in the crestal level of the bone. If we want to reach the
Yes,
forcation area, we have to remove the bone
yes,
coronally. It is not just apical surgery.
yes. It's
And
not
and
only one.
and in the pocket we difficult the action of the MTA. I think if you make the option for a surgery, we must to use resin to seal the area of perforations. I think MTA is not worked with if we have a pocket, periodontal pocket. We must try to seal with resin or another material like that. And then it's very difficult to work
Yes,
with resin in this area.
yes,
yeah, yeah.
And the other prognostic factor in the perforation, I think, is the amount of the perforation. For example, if you have
size.
larger perforations, the long-term prognosis of the tooth and the fracture resistance of the tooth will decrease. And the main failure of such cases is not due to the perforation. It's due to the, for example, vertical fracture or any crack or any split tooth in such cases. And it is more important than, I think, the perforation itself. And we should consider
It creates lots of stress.
Exactly.
It creates lots of stress along the route. Yeah.
And I had an
article in I think it was published about 3 or 4 years ago, and we showed that in that article, if your perforation area was larger than, for example, 2 millimeters, it will decrease the fracture resistance of the tooth significantly. It is very important to consider the area and the amount of the fracture area, perforation area.
At Mona's first case, the tooth was restored with metallic restoration. Is it?
Yes,
It's a metallic
the general
restoration in the first case.
yes, the general dentist restored the tooth by amalgam. I refer it back
Today,
to
I think it's not the best option when we were talking about the stress. It's
yes,
not the
yes,
metal. It's not the best choice. I think. What
yes.
do you think? What do you think about it?
Yes, you are right. I did the root part, and because it was not my patient, I had to refer
Okay.
back to the general dentist, and then I saw that it was with amalgam. So,
Yeah. I think we can use a post,
I think we cannot.
fiber post
Oh,
is the best
That
option. And we have two. You don't use a post. We just make a reconstruction with resin and a crown. What do you think about it?
I think that the post also will create stresses in that tooth because it's already weak, the mesial roots. So the mesial part of the root is weak. And if we go for post preparation on the distal one also, it will create, we can do, what I was thinking, we could do some kind of NIR core. So the NIR core, like 2 or 3 millimeter, we could do it by composite maybe, or that was my option if I was doing the case, not post. To be honest, it will make it weaker, I think.
Okay,
exactly. I'm
Not a
it's
risk though,
not a
guy.
place to put a post. I think. Yeah.
Exactly. I'm not a resto guy because I don't have any experiences on the restoration, but I see that based on the advanced adhesive dentistry and biomimetic dentistry, we don't need to use any post in the molar teeth because the pulp chamber is completely enough to give you the retention of the coronal
Yes.
restoration. And based on the
Yes.
Yes.
minimally invasive concept and biomimetic dentistry, in many cases we do not need actually post nowadays. And the contemporary concept is based on not to use any post.
That
Yes,
is
you are
true.
right. Yes,
Perfect.
that's all right. Yeah.
Okay, if you agree, I will go for the last case and I
Yes,
will
sure.
share it to you. And this
No.
is my case, and I will tell you the history. As you can see, we have a strip perforation at the mesial aspect of the distal root. The patient is a 29 years old man that is going to only have routine visit and just want to check his tooth. And when I get a periapical tooth, a periapical radiograph from the right mandibular molar tooth, I see this actually lesion at the mesial aspect of the distal root. And patient said that the root canal treatment was done about 12 years ago, and now the tooth is completely asymptomatic. But as you can see, we have a lesion at the focal area. And the patient asked me if there is any need for treatment. And I want to ask you about your options for these tooth and this medical and dental history. Are you going to do any orthograde or periapical surgery for this case, and what will be your approach in this case?
It's a difficult case.
Yeah, it's difficult. I want to challenge you.
To be honest, the difficulty is it's a long route and it's a very thin route, and both it's not only the post space perforation. The other route also, the mesial one also had problem like radiolucency, periapical radiolucency. So if we want to treat, we have to treat both routes, and I won't go. It's difficult to do the orthogrades to remove this post. To be honest, it's very long, and we might damage and fracture the root. I want to hear Dr. Gomez opinion.
And let me complete the dental history. There is no probing defect. There is no symptoms, and the patient
Good.
says that the tooth was completely asymptomatic during these 12 years.
I think this is a beautiful case to try to do with the microscope. Now we can see the good aperture. We will remove the good aperture with an ultrasound tip. But Mona said that was a long root canal. It becomes very difficult, the treatment. But along route, if everything goes wrong, we can cut we can cut these roots. I don't know if it's possible. What do you think about it? Now we have long roots. If you cut these roots, the tooth should remain. And I don't know what to think about someone. It's not common, but some people take the tooth out, make the work without the mouth, and put it again. I have no experience with that procedure, but it's possible. I don't know what we think about it.
To be honest, in this case, I was thinking of intentional reimplantation as well. This is what you said. There is a post, okay, if we remove the mesial guttoperca under microscope, but the post in distal is very challenging to remove it. So even under the microscope, for me, it's going to be challenging when the patient doesn't have any symptom. So it's asymptomatic tooth. And so intentional replantation is one of the choices, and episectomy, as you said. So for me, I think surgical intervention here, it's if I was, but I don't know. To be honest, this one is really hard to think about it.
Always the bun is the question. Sometimes this root is long for we have a lot to remove a lot of bone to reach this root. It's not easy. It's not easy.
That's why cone beam city is really crucial here. We need to, and
yeah.
Yes. I want to surprise you more because the patient was me, and this is my right mandibular molar.
So keep it and don't treat it. Keep it.
Exactly. That I intentionally shared that case because I have that tooth for 12 years, and the tooth was remain at this stage for 12 years, and I did not do any treatment for these tooth. I just follow up these tooth yearly, and I see that there is no change in the periapical lesion and the interradicular lesion, and this is very surprising.
But we never know when. But we never know when it's going to happen. It's a problem, you know. When you're resistant, exactly. You fight a lot. You fight a lot. When your resistance goes down, you know what could happen.
And that's the dark point behind these follow-ups. And anytime the tooth will go to have symptoms, and I will feel the pain. But this is very interesting, and so I want to show that
it's not. So, Dr. Ali, this is not asymptomatic. So sometimes you have symptoms from it.
No. I don't have any symptoms till now, and this is very interesting. And I want to show that we have another option, and the other option in such cases is that we cannot, we are not obligated to do any treatment. We can just follow up many cases and see what is going to happen in the long term. And this can be an option for any perforation and, for example, such mishaps. But it is not just any file fracture. If we have file fracture, we are not going to do apical surgery as soon as possible. We will wait and see what is going to happen in the long term. And I am really.
But that's okay. We will help you when we need you, and yeah, I will help you with Mona to take your tooth out. Let's make it at your hands and put it again. It will be fine.
Yeah, I will come to your office.
Let's make it at Mona's office. I think.
Yeah, sure.
Yeah,
I will
because you
ask.
shared the case with us, and we have to do the treatment planning. So let's us give it to us to treat it.
Now it's our case. Now it's our case. We must solve this problem.
Yeah.
Yeah.
I don't have any I don't have any other options. I have to come to your office, and you will do the intentional replantation or apical surgery for me.
Yeah.
That's a, and we will have another life just to show your tooth. It's a beautiful case. It will be a beautiful case.
Yeah. Yeah, it will be a good documentation for you, and you can share it in your classes and your Instagram page, and yeah, it will be a great case for you. Yeah,
Yeah.
I will be a case. I can also be a case report if the healing is going to be good. I can be a case
Yeah,
report
I
in the
think it
literature.
was promising. Yeah.
Yeah, yeah, yeah. Thanks for your comments, and it was a great discussion. I think we have talked a lot about managing perforations, and it was a good discussion. If you have any question, if you have any comments, please add. I will check the actually messages, and I see if there is any question, and I will ask you to answer them. But go on, if
Okay.
you have any comments, I will
They
be
want
happy to hear them.
I'd like to
another
say
case.
hi. I see some of my students and friends here watching us, and thank you for watching us. I think it's a very good discussion. I love to know you personally, not only in the WhatsApp. I think you are much better here in Instagram, and I'm very happy, and we'll see you a lot of times. I think it's going to be a very good discussion every time that we came together. For me, it's a great pleasure.
Thank you. Thank you.
Thank you so much. Thank you, Dr. Ali. It was really pleasure to be part of this webinar. Thank you for organizing this. And I know there was lots of pressure on you. We missed Dr. Mustafa,
Yeah, we missed
but
Mustafa,
yeah,
and it was
Next
a bad
time,
news for
next
him.
time
next
he
time,
will be with us.
hopefully, yeah.
Yeah, we will
And
have
let's pray for his father to
yeah,
be as well soon.
we will
Hopefully,
pray
hopefully he
for
will
his
get
father,
well
and
soon.
I am sure his father will be good soon, and he will back to the home. And thanks for sharing your knowledges, and thanks for sharing your experiences. It was a great discussion, and we were here on the behalf of Expedient Company. Thanks for their support, and it was a great pleasure for us to have the chance to be at the first program of the Endo Leaders Show. We will hear a lot about Endo Leaders Show in the future, and we will see amazing programs, amazing discussions in the future at the platform of Endo Leaders Show.
Thank
Thanks
you.
for everything.
Thank you.
Thank you.
Thank
If
you
you
so
have,
much. Thank
yeah,
you.
thank you. I will share the saved live webinar on your pages, and please accept my collaboration.
Sure, sure. Thank you so
Okay,
much.
sure,
Have a
sure.
great night. Have a
Have a
great
great
night, Dr.
night.
Gomez. Thank you, Ali.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Bye.
Thank
Bye.
you, thank you.
Bye. See
Bye.
you soon. See you in the next programs.
Bye.
See you soon.